This week, we're looking at the hospital industry. It's our second week talking about the supply side of healthcare. Last week, as you know, we looked at the physician side. This week, we'll take another step at the supply side, looking at the hospital side. If you take the healthcare economy and you look at the dollars and where they flow, the hospital industry represents almost 50% of the spending in healthcare. 50% of the healthcare dollar. So 50 cents of every dollar in healthcare is being spent through the hospital. So it's an important industry to look into, especially if you're trying to find how to increase quality and how to lower cost. Hospitals are the best place to look. And so we'll dive into some of those economic examples. So first, let's start about the history. Prior to hospitals becoming prominent across the country, a lot of times they were tied to charity work, philanthropic work. So churches were the ones that were really the ones building hospitals. That's why many of our hospitals today have the names that match saints in the Catholic Church. So churches were the ones that would decide to build a hospital to take care of certain neighborhoods. And when you took a step back, you saw that there was a disproportionate share of hospitals in certain places. And so what the government did was want to make sure that hospitals would be creating everywhere so there was equity in the access to care. And they passed this bill, this act, this 1946 Hill-Burton Act. And the intention of it was to make sure that more hospitals were built in all over the country, not just in certain places based on charity. And this was a government intervention to sort of fix some of the healthcare issues that we had with supply because it wasn't evenly spread out across the country. So since this act passed, it gave monies to municipalities to build hospitals, but then it tied monies, there's hooks to that funding. It tied the monies to say that you must provide free and low cost of care to the poor. So what you saw was a spur of more hospitals in more neighborhoods. And then the hospitals also opened their doors to the poor and made sure that they were providing low or free healthcare to low-income communities. This is an example of government intervention. In our previous classes, we talked about government intervention in impacting the health economy. This is an example of, and we'll talk about it, of how do you increase supply. The normal economy of healthcare did not increase supply, and we'll talk to the reasons why there wasn't more hospitals. So the government had to intervene and create programs that would increase supply. And the biggest one, obviously, was giving money to people to build a hospital. And what that did was reduce the barrier to entry. So one of the reasons why hospital costs are so expensive is because of how big the barrier to entry is. And if you have a big barrier to entry, it means you limit supply. And if you limit supply, the demand goes up. If the demand goes up, the price goes up. And so if you can decrease the barrier of entry, you de facto lower price because more suppliers come in. When more suppliers come in, they flood the market, and then demand goes down. When demand goes down, the price goes down. So an intervention on the hospital side to ensure that there's more hospitals is lower that barrier of entry. We'll get into more details about the barrier of entry. So what did it result in? Resulted in more hospitals and more hospital beds. Not necessarily a good thing. And so there was a couple reasons. You had a lot of hospital beds. You had a lot of people staying in hospitals. But what ended up happening is there was more technology and there was more insurers that were trying to lower the cost. So when you have a lot of beds, you saw the supply chain. What the supply side is trying to do is fill those beds. But on the consumer side, they're trying to reduce costs. Hospitals are very expensive. So how do you reduce costs? Technological advances reduce costs, as well as the way insurers paid hospitals for their services, which also reduce costs. So what you saw over time was a big decrease from the Hill-Burton Act, 1946, big decrease in the length of stay. So people stayed in hospitals 9 days on average, which now is unheard of. Now, 2 days, if that, is the average length of stay. So 9 days on average, all the way down to, like I said, 2016, 2017, you're roughly talking about 3 days max, 2 days. And then also think about the number of outpatient visits. Outpatient visits is when you go to the hospital, but you leave the same day. You don't stay overnight. That also skyrocketed. So you had less stays in the hospital, less length of stay, shorter amount of time. And then you also had some of the 1 day stays turning into outpatient visits so that people weren't staying overnight. And this was done from technological advances, obviously. If you have more x-rays, more machines, you can do things faster and better and cheaper with more quality. And then also insurers started paying something called a DRG, which was sort of a lump sum payment. And that lump sum payment provided an average length of stay for each procedure. And what that did was say hospitals had to make money, would have to beat the average bundled payment for that procedure for them to have a profit. So an example would be they'd give you $20,000 for a procedure with an average length of stay of 2 days. So if that hospital had that same patient for that procedure, got the $20,000, and that patient stayed for 3 days, they would actually eat into their own expenses and they wouldn't be profitable. Whereas if they could turn that patient around in 1.5 days, but they were paid $20,000 for 2 days, they would actually then turn a profit on that money. And so when health plans started paying hospitals that way in this prepayment bundled arrangement, which is like a DRG, then you also saw the length of stays come down as well. So it's trending towards increased outpatient visits. We see that even today, and then a decreased length of stay. So let's talk about some of the arrangements among hospitals and how these arrangements work with physicians. So the two ones that are main, there's a third one here, but the two ones that are main that we see is what people call the physician's workbench, which means the physicians are not directly employed by the hospital. They have affiliation rights to the hospital. And then you have the direct employee model where they work for the hospital directly. An example, if you think of Kaiser Permanente, the hospitals they own, all of the employees in there work for the hospital. They're owned by the hospital. Where physician workbench, what ends up happening is the physicians are community docs. They have their own practice, but they have affiliation rights to work with those hospitals. And there's trade-offs between the two. And then lastly, there's the physician-owned hospitals, which you don't see that much. An example of that in New York might be Crystal Run. They're not a hospital, but they're a big provider group that's physician-owned. But the main two that you see is the physician workbench as well as the direct employee modes. And there's trade-offs. Physician workbench, think about this. We talked about the physician agency, right? So what's the likelihood that a physician is going to refer to a hospital that they don't have affiliation rights to? Is very unlikely. They're most likely going to refer to a hospital where they have affiliation rights, they have referral rights, right? And so right there shows you the power of the physician agency that we talked about last class. The other thing that happens is the physicians that are part of the workbench are not too concerned about the cost and the quality of the hospital because they're not an employee of the hospital. They're worried about their practice. Where direct employees is a different story. The direct employees are listening to the hospital. They get paid by the hospital. If the hospital has certain practices that they want to put in certain procedures on cutting costs, those physicians will listen to the hospital. So that talks about physician loyalty. And so the physician agency might change when the physician is an employee of a hospital versus when they're not. And that gets back to the conversation we had last week around physician agency. And doctors without connection to the hospital may overuse hospital resources. So hospitals are very keen to think about the types of doctors that they bring into the hospital that work there. Some have a hybrid where there's hospitalists that work for the hospital, but there's also community physicians that refer to the hospital. And so these different modes can totally impact your reimbursement, and they can totally impact how expensive cost is. Usually direct to employee hospitalists, direct employees are lower priced because they're getting a salary. So they're not being paid by value, where the physician workbench is not making a salary. So they're getting paid by the volume of services that's rendered. So they're more likely to have physician-induced demand, which we talked about last week. They're more likely to try to have more surgeries because they're getting paid per surgery, where the direct employees are not. And so those are things we have to think about when you're, and from an economic perspective, on how you're going to arrange your relationship with your physicians. And when you think about that, you have to look at some correlations. So here, there's a learn by doing hypothesis, which has strong correlations. And basically what the premise is, that surgical mortality rates decrease when you increase the hospital value. So if you look at this chart, you'll see 3 categories. the lowest 20%. So these hospitals have very low volume for these following procedures. And then the highest 20%, these hospitals are getting the most volume. They're the highest 20% of these various procedures. And the numbers inside the charts show the surgical mortality rates. So an example, and I think the biggest one on the page that jumps out, is the pancreatic resection, right? The hospitals that have the lowest volume of that procedure, their mortality rates are 17.6. 17.6 mortality rate, compared to the hospital that has the highest volume, and it decreases dramatically to 3.8. Imagine that, right? So if you're a consumer, what would you rather do? You would rather go to the ones that have the highest value. However, when we bring into this nuance of the mode of the relationship between the physician and the hospital, if I am a doctor that refers to a particular hospital and that hospital has low value for the procedure I need to do, am I going to refer my patient to that hospital or to a different hospital that I don't have referral rights for, where I wouldn't be able to act on that member? And so this is where you see the contradiction and sort of the impasse of the physician agency that occurs in the healthcare market versus these economic principle of learn by doing hypothesis. The higher volumes lead to better outcomes. And it's tricky. What this would say, in theory, is it would promote an idea of centers of excellence, where you say, okay, hospitals that see the highest value have the best quality, and therefore we should send patients to different hospitals based on how good their outcomes are and based on how good their volume is, right? And that gets into this opportunity called centers of excellence. And part of the Affordable Care Act was trying to get there to say hospitals can't be good at everything. So just like in the physicians where you have specialties, there's physicians who are cardiologists, there's physicians who are OBGYNs. You need the same thing for a hospital. Hospitals should specialize, similar to how Memorial Sloan Kettering focuses on cancer, and certain other hospitals might be children's hospitals, for example. You want that focus because it's so hard to be good at everything. And the learn by doing hypothesis would prove that out. However, the selective referral hypothesis says, no. It's not the high volumes that lead to good outcomes. It's actually that a hospital that has very good outcomes leads to high volumes. And so what this is predicated on is that there's not asymmetric information, that the patient knows the quality of the hospitals, and then that they're actually selecting the hospitals based on how good the outcomes are. For that to happen, you need ubiquity of information so that everyone can see these type of stats and say, I don't want to go to the X hospital for my pancreatic resection because they're not good at it. They have high mortality rates. I want to instead go to this hospital because they're the best. But you would need that type of data, right? And in a perfect economy, there is that flow of data between the consumer and the seller. But we know in the healthcare economy, there's not that free flow transfer of data. But the selective referral hypothesis would argue, nope, if you can do the procedure really well, that will lead to selection. More people will come to you because you do it so well. So it's interesting perspective. Why is it important? Because a lot of times, common sense, we believe physician is more important than the hospital. But McGrath challenges that notion. The question of does hospital experience or physician experience matter, McGrath would argue hospitals with more surgical experience have fewer complications than physicians with high experience. So what they would argue is it's not you get the best doctor from the best school with the best pedigree, and that means your hospital is going to be the best. Rather, it's the clinicians, the staff, the nurses, the labs. Everything that surrounds that surgeon or that doctor is what makes it good. It means that teams of medical workers that collaborate is what makes the hospital the best and have the highest quality rankings and the lowest kind of cost, not just one person who comes in. And that's an interesting piece because I think intuitively people might select the hospital based on their physician. It goes back to physician agency again, versus looking at how well the teams perform. Because the teams actually are more important. Because the doctor obviously can't know everything and can't do everything. So A doctor's only as good as their team, similar to like, a football team. You can have the best quarterback in the world, but if no one can catch the ball, what are you going to do? Type of thing. Okay. So because we talked about how different hospitals can be good at different procedures, right? What that means is they don't compete on an apples to apples basis. They compete very differently. And because we talked about a barrier to entry in the hospital industry, meaning it's very expensive to build a hospital. You have to get the land, then you have to talk about the building, then you have to talk about the staff. I mean, it's millions and millions of dollars of fixed costs to even begin to try to be a hospital. So there's very big barriers to entry. So because of that, there's few hospitals. So think of it this way. You have few hospitals in a health economy. Not only that, of the few hospitals, they're not good at everything. Certain hospitals are only good at certain things based on the volume they get, right? And you can argue whether the volume makes them good or they're really good, and because they're good, they get more volume. Two different hypotheses you can argue. So because of that, we had to come up with an economic term to describe the hospital industry. That term is called differentiated product oligopoly. Very big, dramatic term. What does that mean? Differentiated, one, because not every hospital does everything. Memorial Sloan Kettering is not necessarily competing with hospital special surgery. They're doing two different things. One's focused on cancer as a specialty, one's focused on orthopedic surgery as a specialty, right? So they're both hospitals, but they're not competing for the same patients. Differentiated product. And then what does oligopoly mean? Oligopoly means it's not a monopoly because it's not just one hospital, but it's not a plethora of suppliers like physicians. There's not 1,000 physicians. So oligopoly is a term that means few. So it's a few firms that can control the market. So we refer to the hospital industry as a differentiated product oligopoly because of all the things we mentioned. And so think about the Hill-Burton Act. When those monies were given out for people to create hospitals, did they take another look and say, well, which hospital should we create? Do we need a heart hospital, a children's hospital, a cancer hospital? Or did they let the people who created the hospitals dictate what they built? We have that issue in America where, yes, we have hospitals, but do we have enough hospitals specializing in the right procedures based on the disease burden of the country? Is supply meeting demand? Or can hospitals compete if they're differentiated in the products that they offer? So that's why differentiated product oligopoly makes us look at the hospital industry very different than the physician industry in the supply chain. And if you're going to try to increase competition in the supply chain for a hospital, you have to think about the differentiated product. So we talked about the strict barriers to entries. Few firms is the reason why we call it oligopoly. And then the last piece, which I mentioned before, is services provided by each firm are not perfect substitutes. So remember when we talked about in the first class substitutes. Coffee, tea, they're not perfect substitutes, but they're very aligned. Two hot beverages that have caffeine. If coffee is really, really expensive, people will forego the coffee and get the tea substitute. You cannot necessarily do that with hospitals. Just because Northwell is expensive, it doesn't mean you're going to go to Nassau or Numic, right? Numic Hospital. They're not perfect substitutes. So you might pay more to stick with Northwell because you don't want to go to Numic. And so that right there is inefficiency that's in the healthcare economy that causes prices to be high. When you don't have perfect substitutes, then the demand is less likely to switch to a different product. If they're less likely to switch to a different product, the cost of that product does not go down. And the hospitals, the more differentiated they are, so not just a cancer hospital, but specifically a breast cancer hospital, right? If you're very focused on breast cancer, or not just a children's hospital, but a children's cancer hospital, right? If you have that much of a focus, it's that much more leverage you have to keep your prices high, and it's that much less likely that you have a substitute. So we needed to figure out an index to measure how strong the leverage is of the hospitals so we can understand how differentiated their products are. And one of the methods to do that is with the Herfindahl-Hirschman Index. Herfindahl-Hirschman Index was created to try to figure out the difference between one hospital and its competitiveness compared to another hospital. And the more unique the hospital is, the less likely that there's a substitute. So you see HHI, Herfindahl-Hirschman Index, equals the sum of, that's the big E, S sub I, which is your market share, all market shares measuring, say hospital-specific surgery, how much of the hip replacements in New York City are going to hospital-specific surgery. That would be their market share. And if you solve this, right, and your HHI is closer to 1, that means there's few firms in the market. It's highly concentrated, which means the firms, those hospitals, have the leverage and the prices are higher. That means there is differentiated product oligopoly. There's few firms, and those few firms control the market. So you see that happen in rural areas, right? Like in Albany, Albany Med probably has a very high HHI, where in New York City, there's lots of hospitals, so they're not going to be as high, but because the New York City hospitals are differentiated, it still could be far away from 0, just not all the way closer to 1. And so on the flip side, an HSI closer to 0 means there's a large number of firms in the market, so not a lot of market share, right? Every firm has a little bit of market share, maybe 10% each. So it's not like anyone's owning the market. And that gives the power actually to health plans, because when health plans negotiate rates, they have more leverage. There's less leverage from the hospitals when there's a lot of competitors. Why? Because if they're $1 more than their competitor, the consumer will go to a different hospital, right? This is all predicated that the information is free flow and traveling between the two. So Herfindahl-Hirschman Index is very important because it's the only way we can try to measure this differentiated product oligopoly in different markets. And what you end up happening is if there's a Herfindahl-Hirschman Index that's close to 1, right, it's going to be very hard to lower your healthcare costs because those hospitals there's few of them, they're differentiated, and so they can have more leverage to stop prices from going down. Very important concept. So limited competition. So because of this, there's not a lot of hospitals and there's not a lot of competition. And again, not just due to barriers to entry, it's also because of insurance. So insurance, as much as people like it, it hinders our ability to see transparency, right? You don't know the price, and we'll show you some examples at the end. But the price is the biggest piece, because think about when we talked about demand and the sensitivity to price. You want to see how much a change in price can impact your demand. So a $30,000 hospital visit that is only $1,000 deductible to the person. That person is more likely to have the surgery for $1,000 because they feel like it's worth $1,000. But they never get to see until after the fact, obviously, the $30,000. And their behavior changes because of insurance. Insurance changes your behavior. And that's the concept of moral hazard. Moral hazard for insured patients literally means that your behavior changes because you know you have insurance. The concept is sort of like driving a car. If you have really good insurance, you're probably more likely to speed. You're probably more likely to cut in front of somebody. You're probably more likely to speed through a yellow light, because if there's an accident, you're okay. The damage could be $20,000, but you only have a $500 deductible. So you're okay with getting into an accident because your car is fully insured. The same thing happens for humans. Someone who has health insurance is more likely to go ski on ski trips, is more likely to do adventurous activities, is more likely maybe to go outside without a coat and run out into the into the snow without a coat to run and get something, because they're like, well, if I get sick, it's okay. I have insurance. So moral hazard leads to, one, people taking more risky issues, which means you're adding to the volume that goes to the hospitals. And on top of that, people don't know the true price of healthcare because of insurance. So they're making decisions, their demand is higher because the cost is lower, but the cost is only lower because insurance makes the price look lower. And so you're adding, insurance adds to the demand and adds to the power of these hospitals. Government often sets the price. So we'll talk about this too. Medicare, set by the government. Medicaid, set by the government. Private insurance is set by the free market. But because Medicare and Medicaid are set by the government, if they're ever held too low, the only place where that extra money can go into is the private market. So a lot of times, private insurance is offsetting of the suppression of rates that happens in Medicare and Medicaid. And we'll talk about that further. And then lastly, and we talked about this in this recurring theme, the emergency nature of healthcare means that patients are unable to search for the best and cheapest hospital. So in a perfect world, when you shop for a car, you can shop for a car for 6 months and you can do all your research. You can search online, find the ones with the lowest price. However, in the health economy, we talked about uncertainty, right? That's the basis of health economics, uncertainty. You don't know when you get sick. And when you do get sick and it's an emergency where it turns into having to go to the hospital, you don't have the time, nor do you have the pleasure to try to research the best and find out, oh, let me find out which hospital has the highest volume of my procedure so that I know it has the best quality. You don't have the time to do that. Or to say, oh, let me find the HHI of the hospitals in my neighborhood to figure out which ones have more leverage versus less leverage so I can negotiate a better price. All this stuff is not going on when you have an emergency and you rush to the hospital. Similarly, when you get into an ambulance, the ambulance is not saying, hey, so which hospital do you want to go to? I can go to NYU. They have high quality, but they're cheap. I can bring you out to Stony Brook. They have high quality, but they're expensive. You're not having that conversation inside an ambulance. An ambulance is basically taking you to the closest place, regardless of quality, regardless of price, which is unfortunate, but it also impacts the price. So all of these things are the reasons why hospital costs are so expensive. So the question we ask is, well, do we even want competition in hospitals? Is that something we even want? Because does competition make people healthier? Like, does it lower costs? And so typically we think competition does improve quality and lower prices. However, we mentioned this on the previous slide, ubiquity of insurance hinders price competition. So even trying to get hospitals to compete, it doesn't even matter, because even if NYU is cheaper than Presbyterian, if I can't see the price, why does it matter? Because I'm paying the insurance fee. So somehow, some way, we have to come up with a way for consumers to be exposed to the price of healthcare so that we can actually have competition work in the first place. And that was literally what the consumer-directed health plan was attempting to do. Let me give you a high deductible so that you have to shop and you'll look for quality and you'll look for price. But then again, if I have a high deductible and it's an emergency, I really don't care about shopping. I just want to get taken care of. So you have this catch-22 with the healthcare market. Also, patients are typically referred to hospitals by physicians. So hospitals compete for physicians. So this gets back to the workbench, physician workbench. The hospitals now are thinking about their referrals because that's how they make their money. That's how they fill their bed. So they understand the patient agency, the physician agency that occurs with the patient, and that the patients have asymmetric information. So they're going to listen to their doctor about where they should go for a hospital visit. And so now hospitals, to feed their supply chain, are looking at the physicians because they want the physicians to refer to their hospital. Not because it's the best hospital, but it's the place that they're attached to. And so this turned into this phrase called the medical arms race hypothesis. And early in the class, I don't know if you remember the first week, I mentioned that in most industries, technology lowers the cost of care. In healthcare, it's the opposite. Here is the explanation. Technology increasing the cost of care. What basically happens is hospitals know, I need more volume. So the way I get more volume is I have to have a connection to the doctors, because the doctors have agency over the patients, and patients will make decisions based on their doctors' suggestions. So if doctors refer to my hospital, I will get that business, right? So how do I get the doctors? I'm going to try to have the best technology, and I'm going to try to recruit some of these physicians. That's why you see a lot of hospitals starting to buy physician groups And the reason why they're buying these groups is because they're trying to get down so that the referrals go to their hospital themselves. And if I get the latest technology, the latest oncology machine, the latest lab and x-ray machine, right, then I can I can lure more physicians to work with me because of the technology. So I'm not buying the new lab and x-ray machine because I need it. I'm actually buying it because I'm trying to recruit physicians, which means I'm paying more money for an expensive service, which transfers into the price that I charge, and I don't need it. And that's what the medical arms race is really discussing. And there's lots of empirical research about the effects of hospital competition and patient outcomes. Not necessarily good, but then also not necessarily bad. The key is that there has to be transparency in price to the consumer for the competitiveness to even work. And one of the reasons why it might not be good is because think about that DRG example. If I pay a hospital $20,000 for an average length of stay of 3 days for a particular procedure, and they're trying their hardest to get the patient out in 2 days so that they can take the balance of the money and use as profit, then they might skimp on care and quality might not be as good because they're going after the dollar. So this is why competition not all the time generates higher quality. And that's why, and potentially sometimes trying to get to a low price does sacrifice quality. But we do know we are twice as expensive as the next country. So there should be an opportunity to lower costs without sacrificing quality because we don't have the best quality. And a lot of reasons why we don't have the best quality is just because of this medical arms race hypothesis. So let's talk about the structure, the tax structure for hospitals, for-profit versus nonprofit hospitals. The majority of the hospitals in the US are nonprofit. In New York, by law, all hospitals must be nonprofit. But there are for-profit hospitals. Tenant is an example of a company that basically buys hospitals and they're for-profit hospitals. And there's a question of which has better quality, nonprofit hospitals or for-profit hospitals. But we'll look at some of the benefits of being a nonprofit versus some of the implications of being a nonprofit. So why would someone decide to be a nonprofit hospital, right? In New York, you don't have a choice, but why would you be a nonprofit hospital? The benefits is you're exempt from taxes. So think about this. There's for-profit doctors, WestMed, CityMD. These are for-profit physician groups. However, hospitals must be nonprofit. There's for-profit labs. There's for-profit pharmaceutical companies. There's for-profit health insurance companies, yet hospitals must be nonprofit. But the benefit of being a nonprofit is the exemption of taxes. So all the revenue that's made by a hospital, they're not paying any taxes on that revenue because of their nonprofit status. The other benefit is people who donate to that hospital, right? Like St. Jude's, anyone who donates to the hospital, they receive a tax deduction. They don't pay taxes on that donation. So people are more likely to donate to nonprofits because of that tax savings. But there's implications to being a nonprofit. The number one implication is you can't sell stock. Why do you want to sell stock? The stock is a way that you get money so that you can build on your business. So I have shares. I sell shares on the open market. People buy those shares. When they buy those shares, it infuses my company with money, and I can use that money to build a new wing, to hire a new doctor, to maybe expand into new procedures, right? But if I can't sell stock, how do I raise revenue? The only way nonprofits can raise revenue is through debt. They have to lease, they have to get a loan, they have to borrow money. They're not able to get money from selling shares. So that's a big implication, which means transformation, technology advancements in hospitals is hard because they're nonprofits. They're doing it off of debt. They're not doing it off of selling shares, right? They also can't distribute profits to their owners. So in a for-profit world, shareholders, the reason why they invest even more money is because if the company makes money at the end of the day, they can give the profit back to their shareholders, right? Can't do so in a nonprofit. Why? Technically, a nonprofit is a public good. It's owned by the public. Since it's owned by the public, you can't distribute profits back to the public. And the reason why it's owned by the public is because it's doing something that probably the government should have been doing, right? Rendering healthcare. And so it's considered a nonprofit. It's not a private company. Um, and the other implications of a nonprofit status is restricted to certain charitable activities. So when you're a nonprofit, you fill out something called a 990 and you have a charter. And when you get approved as a nonprofit, you basically say, this is the work I'm going to be doing. If you go outside that work and you start making money in that work, right? Not in the work that's in your charter, you could lose your nonprofit tax status. So essentially, like say you were Northwell, but you started a for-profit arm, right? Because I know they own an urgent care clinic. If that for-profit urgent care clinic was making more revenue than the hospital itself, then the state might look at that and say, are you truly a nonprofit? Right? Or are you a nonprofit in disguise? So you have to be careful. So there's restrictions in the certain charitable activities that you can do to keep your nonprofit status. So why do nonprofits exist? There's a bunch of theories. I'll go through some of them. Altruistic motive theory. Entrepreneurs prefer altruism over profits. This is just, I'm going to be in a business. I want to do good versus make a lot of money. So then you see this social entrepreneurship industry growing over time. I think it's a good thing. There's a government failure theory. This is the one I subscribe to. I believe this wholeheartedly, that there's times where government can't do certain things. And when government can't do certain things, nonprofits step in. And to me, that's the reason why they get nonprofit tax exempt status, because technically they're doing the work of the government. So why pay taxes if it's actually, we would be doing it anyway through our tax dollars. So if you think of government failure theory, it would be this similar to hospitals that were created by, say, a church. The government's supposed to deliver healthcare. The government should have a state hospital like SUNY Downstate or like Stony Brook, or a city hospital like H&H, right? But there's not the city and the state cannot create enough hospitals for the demand in the New York market. So nonprofit hospitals like Presbyterian, like Montefiore, like Northwell, like Stony Brook, or not Stony Brook's a state hospital, but like other hospitals, nonprofit hospitals stepped in because the government couldn't have enough hospital beds. So the government had to step in. Nonprofits had to step in. Asymmetric information. This is interesting. Donors trust nonprofits more with money. So if you're a nonprofit, in theory, you're saying you're not in it for the buck. You're in it to do something good. And so donors are more likely to provide you with money because they think you're going to do with it the right way. So it's asymmetric information. It's like if I don't have enough information and I have to trust somebody, I trust a nonprofit over a for-profit. And then lastly, a cynical view is that nonprofits are just for-profits in disguise, and profits are actually distributed back to the CEO or through non-monetary benefits. And this is a theory of saying they're a nonprofit in name only. They're not really a nonprofit because they're acting like a for-profit. And that's a cynical view, but there's different theories. And again, I subscribe to number 2, government failure theory. Nonprofits exist to fill the gap where the government can't operate or fall short. So, because of the HHI, Herfindahl-Hirschman index, right? Hospitals can charge different rates based on how much leverage they have, right? When they display their list of rates, it's called a charge master. And if you look across the country, rates can vary very widely on a charge master. And why is that? It's because the supplier is basically charging a price that they think that they can get. So tremendous variability, even in New York. And I'll show you some examples of that variability of how a chest x-ray can range from very low to very high, right? However, what you see in the charge master is rarely paid for by both patients and insurers. We negotiate down. We either negotiate off of Medicare or we negotiate off of charges. So we negotiate down that rate. What that charge master rate is for is someone potentially who's uninsured that has no insurance. That's like the retail price, not the negotiated contracted price. And a lot of health insurers contract their rates. And in theory, the same procedure could have different rates from different health insurers. And that's because those health plans have leverage too. A health plan with 5 million members can negotiate a lower rate for the same procedure as a health plan with 1 million members because they have more members. So the hospital basically says, I'll concede a lower price for more value. And so the rate goes lower. So these are negotiated rates that get reviewed potentially annually or every 3 years or every 5 years. It's the bargaining power between a hospital and a health plan. And why does this matter? Because despite all this, we still have uninsured populations. And uninsured populations or underinsured, meaning they don't have enough insurance to cover them, they have big deductibles. When they go to the doctor, they are not paying their bills. And so these hospitals are stuck with uncompensated care. And so what do we do with uncompensated care? There's the last resort laws, and this mandates that hospitals treat all patients who enter their emergency room. Because of this, we have moral hazard because people know it doesn't matter if I don't have an insurance, I still know that if I walk into an emergency room, I can get taken care of. So that actually gives people a reason not to buy insurance. But when that does happen and they lack the resources or insurance to pay for care, hospitals have out-of-pocket expenses that's not covered. So what do they do with it? They do with it something called cost shifting. And essentially what cost shifting is, remember I talked about how Medicare rates are mandated by the government and Medicaid rates are mandated by the government, but the private insurance market is not mandated, and those are negotiated between payers off the charge master or potentially off of another scale, right? What ends up happening is hospitals say, hey, of all my expenses, 3% I did not get compensated. It was uncompensated care because people came into my hospital, they never paid my bill. So I'm going to shift that cost into my next negotiation with the health plan. There's cross-subsidization happening because it's like, I have to pay for these expenses. So people with insurance end up paying more money for people who lack insurance. And that's why there's an argument to have everyone covered by insurance. Because when that person goes to the emergency room, they're going after delaying their care, and they're also going to when it's the most expensive, and they're actually getting charged the most expensive price because they don't have insurance, so they're getting the charge master rate. 3 horrible things in a row for uncompensated care. And then the hospital doesn't make the money, and they're not getting it from Medicare, they're not getting it from Medicaid, so they go to the private insurers and they negotiate this rate high enough so that they can cover potentially what their uncompensated care would be. So rich patients pay for poor patients, cross-subsidization. And as I mentioned, reimbursement rates for private insurers are much higher than Medicaid and Medicare. So this is an issue. We want people to have insurance, so we have to eliminate the uninsured populations so that we're not cost shifting to people who do have insurance. And the worst thing ever is, as you cost shift to the people who do have insurance, those insurance prices raise, causing more uninsured people. It's a vicious cycle. So here's an example of some of the pricing that happens with consumers. So you can see what like a charge master rate would be versus what it looks like with insurance. So there's a website, and please go check it out and peruse, called fairhealthconsumer.org. And what fairhealthconsumer.org attempts to be is what the Kelley Blue Book is for cars. What it does is you can go in, by zip code, and look up procedures to find out how much the price is. And the way they get this data is they get aggregation of data from all these hospitals on what was charged, and they can come up with an average based on different zip codes and different criteria. The reason why this nonprofit exists is actually from a lawsuit. The Attorney General sued a bunch of health plans in New York on the basis that they were using this data to pay hospitals less money, and said you cannot collude and work with each other on how much to pay hospitals. You can't share that kind of data amongst yourselves. That kind of data should be transparent to the consumer, because if we make it transparent to consumer, in theory, prices should come down, right? So that lawsuit was millions and millions of dollars. The outcome of that was they're going to use the millions of dollars in that lawsuit to create a nonprofit to show transparency called Fair Health Consumers. FairHealthConsumers.org launched, and now you can look up procedures based on zip codes and find and do cost comparisons. So on this one, this is low back pain. This is showing on average how much it would cost. So you can see in Manhattan, $16,900. I'm sorry, in Rockville Center, $16,900. In Manhattan, $17,500, right? That's the out of network price. But then look at the red box in network. That's the negotiated price on average that insurers negotiate. So you can see how much they're negotiating down from $16,900 all the way down to $6,900, right? Similar to Manhattan, $17,500 all the way down to $7,200. So they're negotiating down to basically a 90% negotiation, the reduction. So if you didn't have insurance, you're paying the higher rate. And with insurance, you're paying a much lower negotiated rate on average. And you can see the differences in doctor's visits, labs, tests, et cetera, et cetera, et cetera. The glaring thing there is radiology procedures. It's $11,000 in Rockville Center. It's $8,300 in Manhattan. So one would argue Manhattan probably has way more radiology places and supply in Manhattan versus in Rockville Center. And so because they have so much more supply, the price is a little bit lower versus in Rockville Center, maybe not as many places to go, so the price is much higher, and you can see the difference, right? And then the ability to negotiate the rate. So it's $11,000 retail price, but it goes down to $4,500. The Manhattan is $8,300, but it gets down to $3,400. The ability to negotiate gets back to HHI as well. How much discount are you giving? And then you can see like the lab test, $569 down to $128, $321 down to $96. Labs is another example of there's probably way more in New York City. And since there's a lot more in New York City, with lots of supply, the price goes down. Another example, and this is a more example for a hospital, is hip replacement. So now we're talking about a hip replacement between Rockville Center versus Manhattan. The big glaring number, right? So 61,000 out of network in Rockville Center versus 78,000 in Manhattan. Now here's the difference, and this is a good example. Rockville Center has less places potentially to get a hip replacement surgery than Manhattan, yet Manhattan has the higher price. And this, I would argue, is because of differentiated product oligopoly. In Manhattan, because you have hospital surgery, and you also have the Joint Hospital by NYU, and you also have the hip center with Presby, there's very specialized hospitals that concentrate on hip replacements in the city. And because they're so specialized, there's few firms. It's an oligopoly on hip replacements. And so they can demand a higher price in Manhattan. So even though there's more hospitals in Manhattan, there's less specialty hospitals specifically focused on hip replacements, which can demand a higher price. Where in Rockville Center, between Mercy Hospital, that's right in the neighborhood in South Nassau, potentially not enough ability to demand a higher price and not enough specialization to say we really only concentrate on this, so I can demand a higher price. And that you can see in the surgery. Rockville Center, $41,000 negotiated all the way down to $4,900, where in Manhattan, it's even $52,000 for the hip replacement surgery, and they only negotiated down to $16,000. Still a big negotiation, 70% discount, but not as deep as the surgery in Rockville Center. So those are examples, I hope, that bring to life this issue that we have with hospitals and shows the contributing factors as to why hospital costs are so expensive.